Hello and welcome to Metis Kompas. Today we have a special guest with us, Dr. George Stathopoulos. Welcome.
Thank you for inviting me.
Thanks for coming. Dr. George Stathopoulos graduated from Patra Medical University in 1995, obtained his PhD from the National Kapodistrian University of Athens in 2007, and habilitation from University Teaching at Ludwig Maximilians University in Munich in 2021. He has been trained in intensive care. After specializing in research on lung cancer and malignant diseases of the thorax, he obtained his pulmonary physiology specialty title in Athens. Dr. Stathopoulos accumulated over 3 years of clinical experience as a team leader at Evangelismos Hospital, more than 600 hours of university teaching, publishing over 150 international papers in reputable medical journals, authored around 10 chapters in medical books, secured over 3 million euros in international research grants, and received several awards from the European Respiratory Society. Welcome.
Thank you. Thank you so much.
It's an honor to have you here.
Thank you so much. It's an honor to be invited.
Yeah, so we always start the podcast with a question to get to know you better. So our question will be, is there a particular moment in your career or life that shaped you into the person or doctor that you are?
Yes, this was in 2009, actually, 10, when I got my ERC grant. And so I got frontier funding from the European Union for 2 million euros worth. And I could shape my own group and my own research in Patras in Greece. So I left the United States, came back and built my own lab as I envisioned it. And this gave me the freedom for the next 10 years to do my research.
I'm curious, what was about research that you were particularly excited about? What drew you in?
Pleural disease. So I was working on malignant pleural effusions. At that time, the field was steered by Mark Nopen, your countryman, Mark Nopen, Rich Light and stuff. And malignant pleural effusion was considered as a mechanical artifact, so defective plumbing of the pleural space and accumulation of the pleural fluid. So I think I pioneered this field in showing that it's a biologic process. So it's a cytokine and chemokine storm that draws exudates into this space. And a few clinical trials were started based on my basic research. And also today, these people get biologic agents as therapy. Back then, they didn't. So I think we did something there. But everything that starts in your career has to have a finish.
Just a question about that. What led to the frame shift to see the problem from a different perspective?
The frame shift was that observations, because we had a clinical cohort of pleural effusions in Athens, Greece, and then in Patras, and then in Munich. The frame shift was that we found inflammatory markers in these effusions. So you have a malignant pleural effusion, and they would think that the cancer blocks the stomata in the pleura, and so the drains, so the fluid cannot drain. And this was the paradigm back then. And we measured cytokines, chemokines in these fluids, and they were so high, even higher than parapneumonic effusions. So this was kind of the observation that led to the neutrophils, monocytes, a lot.
We're deploying what our ancient Greek ancestors did, like observe and look at nature and try to understand it. That's beautiful.
And then get the right biological samples, the right approvals from patients, and then set up the relevant mouse models. This is also what we did. There was no mouse model of malignant pleural effusion in 2000. So we made. And, Papa Nicolaou, many medical students and doctors don't know that he did not only found cytology of the female cervix, but every cytology. So all what we know, we can diagnose cancer from the pleural fluid today because of his work. And do you use Light's criteria to differentially diagnose pleural effusions? And so Rich Light was my friend. We have published a lot of papers together. He died last year, unfortunately. Yeah, he had a ton of data and he got a deadline. He was pushed. So by tomorrow, if you don't hand in your thesis, you're disqualified. Harvard University, 70s. Yeah, so he compiled Light's criteria out of neat, and now we all use them all over the world. He did an observation. Okay, it's wrong that he was pushed to this observation, but he made an observation that changed clinical practice fundamentally.
So we're here today to talk about your work in prevention of tuberculosis. Would you be able to introduce the listeners to the background of what you're doing and what exactly you're trying to achieve?
So, you know that if you get infected with Mycobacterium tuberculosis, nothing happens. Most of the times, 99% of the times, your body and your immune system will contain the bacillus and it will go into the dormant state like Count Dracula. So it's ensliming itself in this mycolic acid, this horrible, disgusting thing, and it evades immune recognition, right? 5 to 10% of the people that are infected and develop a positive tuberculin skin test or a positive IGRA, so interferon gamma release assay, they will progress during lifetime to active disease. And there are many risk factors that increase this chance of you getting sick once infected. Diabetes mellitus, HIV infection, renal failure, hemodialysis, biologic agent therapy, immunosuppressant therapy, transplantation, pregnancy, lactation, and immigration. Immigration is a hard blow to the head. You are deprived of basic human rights and needs for a period of 4 to 6 months or 2 years. So I came to Cyprus end of October 22. The situation here in Cyprus, there is only one refugee camp. So for refugees and asylum seekers, is called Purnara. Purnara has a capacity of 600 people. So I came to Cyprus to work for the public healthcare system in Troodos Hospital in Kyperunda, so in the mountains. Okay, and this hospital has a clinic that devotes itself to tuberculosis. Okay, so they were screening people, and then treating the sick people, but there was no prevention program. So people at the Ministry of Health. So when I came, Purnara, with a capacity of 600, had 2,300 people living there, most of them sleeping on the floor. So they were seeking for a doctor for a long period of time, 2 or 3 years, that would start such a prevention program, because it was observed that people came in with a normal chest X-ray and with a positive tuberculin skin test, and they were released, so they were incorporated into Cypriot society and economy and everything, and Cypriots are very good at it, I must admit, much better than the Greeks. And but people got sick. So you had 80 to 100 cases of active TB per year, and if you would ask those people, hey, Nikel from Nigeria, 41 years old, came here with his wife and kid and baby, and after 1 year, he got sick with tuberculosis, and he lost everything. He lost his job, and nobody would hire him again, and he lost his home, and he lost his mental health, okay? When did you come to Cyprus? 1 year ago, 2 years ago, 3 years ago max. So they sought to start a TB prevention program. No pulmonary or internal medicine or infectious disease doctor would like to take up on this, because there is no financial interest in treating TB patients with no health insurance. So alien TB patients with no YESI, this is the public health insurance in Cyprus. So I volunteered for this. I saw an opportunity there, and I think it worked out. So preventive TB treatment, latent TB infection treatment has to be programmatic. So you have to set a framework and treat all the people the same way, right? So this was also a process that lasted months with the help of my colleagues there in the mountain hospital, Troodos Hospital. We set this up. I did most of the work, and I think we had success. We treated 1,600 people. We performed more than 2,500 medical visits, follow-up visits in 16 months. And the most important thing here is that these people now are working in hotels, in the gastronomy, in coffee shops, in Larnaca, all over Cyprus. I have friends, so my ex-patients, and they are healthy. No one of them got sick.
What made you take upon this job?
This was my inclination in life and my beliefs. So I chose pneumology because it helps the poor. Because lung cancer, tuberculosis, these are diseases of COPD, diseases of the poor people, of the underprivileged. So because of my socialist beliefs, I always wanted to follow this track, and it turned out to be perfect for me. I mean, I was actually forced into pneumology because there was no waiting time for your specialty training back then, which was 5 years. There was no waiting time. So there is a social aspect, to your work, and you don't go into the hospital or the research center just to make money. You also try to help the people. And I think it's a basic aspect of medicine, right?
What did you encounter and what were your steps? How did you lay out the strategy of building such a prevention program?
I encountered a very negative behavior from my colleagues. My colleagues were set on treating only the sick people and incarcerating them. Thank God. I had also other people that supported such an undertaking in the Ministry of Health. Kostas Konstantinou, he's the responsible for public health for infectious disease, and also the CEO, general manager, Mr. Stavridis, because they also saw a medical opportunity, but also a financial opportunity in this program. In a small countryside hospital, every year we made 1 million euro for the system. Okay? So you don't only turn 1,500 people at risk of active TB at non-risk for active TB, but you also make money for your system. People with latent TB, most of them will need pre-treatment tests, blood tests, X-ray, Mandu test. This all is financed by the Ministry of Health, also partly funded by the European Union.
Is the treatment, the rifampin and all this extensive long-term heavy treatment, is that all also publicly treated?
Everything.
Yeah.
What we managed is by starting this program and gaining recognition, these underprivileged people had no rights, no access to free drugs or whatever. In the beginning, we were allowed only to prescribe TB medicine. So rifamazine, so combination tablets, rifampin and isoniazid. And if they had side effects from the medicine or if they had other problems, these people are not free. They live in a closed camp. So, for example, if a patient had asthma or if a patient had allergy or if a patient I couldn't prescribe to them other medicine. So we set up a mechanism to connect these other symptoms with TB or with TB therapy so they got everything for free. So I think we helped a lot of people.
What I do not really understand is that, there you have the Cypriot community and then there are people coming from outside, and then the Cypriot government is accepting to spend money to prevent disease in people coming from another country. I would expect people to think, oh yeah, why don't we try to stop people from coming from another country from the first place?
This is what they are doing now. They have a new Minister of Internal Affairs and of the Asylum Service, and there are thousands of people waiting in the green zone, in the buffer zone, or they are pushed back in the sea which is a crime against humanity. This is what they are doing there now. Back then, in 22, early 23, we had influx of thousands of people every month. Imagine 67,000 refugees or asylum seekers per year in 23, and then 74 in 24, I think. So they stopped this. But, these are different authorities. So you have the Ministry for Internal Affairs, the Ministry of Health. Their concern was to, even if you spend some more money, to keep the community healthy. There are also enlightened people in there, in this ministry. And, I have the data at your availability. You spend 2 or 3 times more money to prevent TB than to actually just cure the people that get sick. We spend 2 or 3 times more money. But it's worth the while because it's human life. And when these poor immigrants that come here and take up all the dirty jobs, all the low-life jobs, so cleaning maid in a hotel or etc., etc. So when they get sick, they lose everything. They have no buffer zone like we do. Like you have relatives, you have friends, you have a good professional life, you have a good income, you have a healthy status. They're on the brink. And when they get TB, they lose everything. So this is why the ministry did this. And I think this is a plus for the Ministry of Health, for the government, because they could tell me we don't sponsor this. Right? And this is, I think, one of the biggest TB prevention programs in Europe. One of the biggest.
I'm really interested with, do you operate independently or do you integrate with primary care and hospital care in the community? How does that work?
In the beginning, sir, because colleagues didn't want to participate, we had to operate independently. So we made a program which includes everything from A to Z. So how will the patients be welcomed? How will they be accommodated? Will they have access to clean water? Will they have access to clean toiletry? Exactly what will be done and stuff. Even what will be the labeling of the offices? What will be the prescription for a 35-year-old child or adult? Because some people from sub-Saharan Africa are under 35 years. What exact drugs will they be taking? How much they cost? And everything. So in the beginning, we had to operate independently because we had no volunteers. Nobody wanted to deal with this thing. With time, our center, we became, I don't want to say famous, but we became known across Cyprus. And colleagues from primary care, mostly pneumologists that were refractory to cooperating in the beginning, then they started giving us appointments. So in the beginning, we had to invite all those people. Once on the treatment, they were released from Purnara. So they were not considered to be a health threat to public health in Cyprus, right? So after 1 month or 2 months, they came back to us. And one was a maid in Paralimni. The other one was a coffee maker in... and it takes 6 hours to come from Paphos to Kyperunda. So in the beginning, we started by force, alone, and then even my colleagues in the same hospital, they didn't want to cooperate. Now they're running it themselves.
It's truly inspiring when nobody believes in it, but you strongly believe in something, you build it, and then you just focus on it, and over time, people just come. Did you expect this to happen?
No. Back then, I was hoping to continue this program forever by myself. I didn't expect anyone to be interested in this program. But then I got phone calls, I got from colleagues and stuff, and inspiring phone calls and empowering phone calls and meetings. And I started believing in it. When I started this program, we had a clinic, a TB clinic with 14 beds. It was always full. So people were waiting in queue, in line, in Larnaca, in Nicosia, to get a bed there with active TB. Just before leaving Troodos Hospital in early September 2014, the clinic was empty. We had 2 or 3 patients. So I think it works. I think the people saw it, the people recognized it, and they are now cooperating. Yeah. But you're always alone in the start, right? When you start something new.
Well, it's a little bit of a pattern sometimes we see is that medicine, however far ahead it is in research and technology, is ultimately quite conservative in adoption. And it's sort of that thing is that you have to have people prove it.
Yes.
And to do that is expensive and difficult and high risk. And
yes.
And the question is, how do you then do that effectively? And it seems like you've found a model.
You have to push yourself to the limits. Röntgen, when he developed it, he could patent it and be a millionaire. He didn't. He assigned it to the public for free, his invention. He went bankrupt. He died in poverty. You have to sacrifice. We sacrificed hours, overtime hours, unpaid hours. We sacrificed here for every insured patient, you get a bonus pay at the end of the year, right? You sacrifice this because for these patients you get nothing, right? But you have your pluses. If we go now to Finikoudes Beach, I will find at least 5 of my ex-patients from Nigeria or the Congo, and they will treat me very nicely. Okay, they will offer me to buy me drinks or food. It's worth the while. It's the reasons that drive you to become a medical doctor, right?
How do you cultivate this attitude?
Now I'm a professor at the University of Cyprus, visiting assistant professor. So I show my students the data from the program. I talk to them about lung cancer and about all the diseases of the poor. I explain to them that money is not enough, an incentive to be a medical doctor. So my students, I was moved the other day. So we do consults, for example, you are a cardiologist. You will be expected every day to also look at patients from other clinics, right? So I'm invited to general surgery to see a patient, and there is a young bursche, a young guy. Professor! So he was my student in Patras, Greece. So I was teaching physiology there. And, by personal contact, you cultivate this, by the way you teach, and by the way of example. You see how I'm dressed, so you understand. By the way of example.
When I listen to it, I have this idea in my head. It's very interesting that you have in migration, people with a migration background, you have a very vulnerable population because you get both the cortisol, maybe mediated immune suppression, and then the extra contact with damaging environment. It makes me think, what other diseases would it be worth thinking about? Does this population need extra screening and prevention? Has that been something that you've considered?
We are not entitled to screen for other diseases because I'm a pneumologist. So the massive transmissible disease that's in my field is TB, tuberculosis. But they are screened for malaria, they are screened for Treponema pallidum, for syphilis, they are screened for viral hepatitis and for HIV. And people that are living with HIV, they get special treatment. It's actually here in Larnaca, in the general hospital. And I had such patients. In the how is it politely said these days? So in the less developed world, so Southeast Asia, Sub-Saharan Africa, so people die at the age of 50 or 60 at a median because of transmissible diseases, infectious diseases. We live till the age of 80 plus, And we develop Alzheimer's, we develop cancer, and we develop... So it's just that these people transition from one world to the other. And, here they have a chance of living till 80 or more. Right? So we need to protect them to cure them from these diseases that they carry with them. Yeah. I don't know if prevention programs for the other transmissible diseases are in place, because, you always need to find also the right people. Is anybody interested? So I don't know is the answer.
One of my questions that comes into my head is what are the core lessons you've learned from running this project, and what would you give to other people who are interested in doing similar things?
First of all, it's the concept that drives anatomy, pathology, do more or less well. So don't be too meticulous. These people need help, and you have hundreds, thousands of them waiting for you. So don't see 10 patients a day, see 50. I was seeing 50 a day in the beginning, okay? And do more or less well. If you miss one case, it's no problem. Second is sacrifice yourself, but only to the extent that you can continue surviving, because then, okay, get help. Do it programmatically. So don't treat every patient individually, because this will lead to disaster. According to WHO guidelines, treat programmatically. And don't sacrifice yourself to those people in other ways other than medicine as their doctor, because these people need money, they need food, they need favors, they need whatever, okay? So if you start sacrificing yourself in other terms, so giving them money to go and buy something in the cantina, then in the end you will have no power to continue this program, because you are encountering an alien population, people with other beliefs and habits, right?
Mm-hmm. How do you, not give in? Because you're a doctor, you're made to help people, and you are sensitive in doing so, and you have your expertise, medical expertise, and then all these other aspects, the social, and maybe the mental things come in, and we are always educated in a holistic manner. See your patient as a whole, try to help them, be like a mentor to them. How do you make sure you don't cross the boundary and be in your own expertise?
I crossed it many times, and then I felt the frustration and the disappointment when you are being exploited, for example, right? I crossed also the boundary many times towards the environment. So this hospital where we run, where they are still running the program, is in a small village of Cyprus called Kyperunda. And in the 30s and in 35, the British built this hospital, and the British doctor came and started the TB program there. Back then, everybody had TB up there. Everybody had TB. It was so common in Greece and Cyprus. Nowadays, only the poor asylum seekers and refugees have TB. So you also have to cross your boundaries sometimes towards the local population. There was a lot of racism. They were not even allowed to enter the cantina, the poor people that don't even have active TB, just latent TB, right? So you cross your boundaries but doctor, when you start something new, you take your risks, you take your chances, you cross boundaries, then you regret, you come back. We had to reshape the program many times. For example, at some point, the most important switch was, in the beginning, we were the only ones in Cyprus I was the only one in Cyprus that could deliver free TB drugs for prevention. Okay? In the first 750 patients, we saw that the compliance rate was really, really low, although we used the most modern TB prevention regimen, so 3 months of HR, isoniazid rifampin, 3 months. It's the shortest, it's the most effective, because the people could actually not afford, in terms of money and in terms of time, to come to our hospital from Paphos or from Paralini. So what we did then, we started a series of contacts with doctors in the other hospitals, and we said, hey, a follow-up visit takes up 5 minutes of your time. It's nothing. So you ask 5 basic questions, 10 basic questions, you prescribe a blood test and the drugs, and bye-bye. So we got them to cooperate, but we crossed our boundaries many times. And I think I'm not entitled to answer your question. We have to ask the doctors from the Médecins Sans Frontières, which are more humanistic than I am. The reasons we did this program was not only for these poor people, but also for the Cypriot population, to protect them from incoming TB infection. So, yeah, obviously I like to talk a lot. I'm a professor at the university, so we are made for talking. But the answer to your question is, when you do something new, of course you will cross your boundaries and you will be exposed. Are you ready for it? Or do you just want to continue what your predecessors did?
I have more of a practical question. How do you communicate with, on compliance, how do you communicate with these patients effectively?
In the beginning, not at all. Okay? In the beginning, not at all, because the authorities of the immigration department, they didn't send us translators. The hospital didn't provide us with translators. I had to start to learn a little bit of French, a little bit Arabic, I had to use a translator software on my handy. I had to push. After a while, for every patient, they were obliged by the Ministry of Health to send us translators. Second, body language. Third, if these people, okay, you have no way of verbal communication. If they see you as a human being and that you treat them as human beings, you give them 1, they give you back 10. They are people that were violent in Purnara. They were coming to us, and they were like sheep. They become compliant, and you just need to persuade them that you are doing this for their own good.
How do you do that? Like, not only persuasion, because you don't have the power of language, but how do you stand there as a doctor, and they respect you, they trust you?
You talk to them, and we did group sessions. So the scheme of doing this was not individually. So, Christiana, you have latent TB, and you need to take those drugs. Take them, bye-bye. It was an hour of talk, maybe more. And there were translators there. If there were no translators, I use my handy, okay? And you talk to them. What are your risks? And the risks need to be individualized. So nobody will take drugs for the community. They will only take medicine if they think it's good for them and the community. And there is a way to do this. It's the tuberculin skin test, so TST in 3D. It's developed by Dick Menzies, one of the largest TB authorities in McGill University in Montreal. And it allows you to put in, it's a software available online, and you can estimate the individual risk of, for example, there were patients that were 60 years old and that had a 3% lifetime risk till the age of expected survival, 82 for women. And I didn't give them medicine. 3% is not a high risk, right? But there were young people that had 70% risk or 60% risk. So you need to use your science. You need to translate it to the lay language and to explain to them why it's good for them to take prevention medicine. So in every session, we started with 50 people per day. This was obviously too much. We stayed until the evening. Then we switched to 20. Now, in the end, with the reduced migration fluxes, we went down to 12 or 10 people per day, so you have more time to talk. So we did a blood draw to assess basic biochemistry, and then we talk to them. You need to explain to them how to take the medicine, why the urine will become orange because of the rifampin, the first tracer drug in medicine, right? People don't know that. And you need to give them contacts and phone numbers and everything, because these people have no resources. If they have a side effect, they don't know where to go. You need to tell them exactly what to do without being superior.
Which is something they encounter all the time, I imagine, in a country where a racism towards these kind of people could be prominent.
Unfortunately, racism throughout Europe rages. And I think, because you are colleagues, I think you cannot be a good medical doctor if you are a racist. And I think we should frontier the fight against racism, being medical doctors, because we are doctors of everybody, of the smokers, of the poor people, of the fat people, of the infected people, of the prostitutes, of everybody, right? We cannot take money from a company like GSK that said back in the 80s that why should we develop a drug against HIV? It's only 1 million infected people.
How do you have the patience to do this every time? Every time 20 new people come, you have to explain the same story. You have to educate them, the painful process. How do you do that?
It's a hard job because before the patients come, you need to evaluate their tuberculin skin test. You need to go on. We have the PAX system where we watch the x-rays and stuff from all over Cyprus. So you need to spend time. And also, I prepared informational material. So every patient got directives and information about TB, about latent TB, about everything. Every patient got their prescription for the first visit and for the second visits to ensure that they get their drugs. So they get 90 days of therapy. And every patient got a thank you letter from me personally, so that they participate in our program. And every patient, because when they are released, so once they entered the program, they were released by the Ministry of Interior, okay? They need to find a job. To find a job, you need a health certificate, right? So you need to go to a doctor privately to pay them 50 euros or more to get a health certificate. And you don't know if this doctor will give you your health certificate because you have latent TB. So I gave them a health certificate out in front, in Greek and in English, so they can work. Because if they can't work, TB prevention is useless. They cannot eat. You understand? So there is a lot of preparation. There was a lot of help from other people. So the chemists in our laboratory, they had up there in the mountains 10, 20 people per day. I doubled their work, okay? The people at the reception of the hospital, the pediatricians, because if you are under 16 years of age, I cannot treat you, right? You need a pediatrician. So we did this together with the pediatricians. And they also made no money out of this. So I got a lot of help. But yes, you need a lot of preparation. We go with, so my partner Steffi, 2 liters, or here in Finikoudes Beach, and you have a Syrian guy or a Congolese guy going, "Oh, doctor, how are you?" So this is enough.
Makes it worth it.
Yeah. But it's tough. If you treat programmatically and not individually, there is a lot of preparation.
Yeah, I can hear programmatically come forward multiple times, and I can imagine that is exactly what you said. So having groups of people, or also having a protocol, let's say, that you follow and being systematic. Are there other things that doctors can incorporate to be programmatic and more effective in treating such large populations?
They need to cooperate. You always need, for example, I needed a pediatrician by my side. You need all the infrastructure people, so chemists, you need the reception of the hospital. If they say, no, you have no active disease, go. For example, you need to cooperate with the authorities, and you need to do a lot of groundwork. It's not that you can say, hey, I'm going to go to Uganda and start a big program tomorrow. No, you need to plan carefully, and then, of course, sometimes adjust, but you need to write everything down, and you need to be very well informed. Imagine if I followed the wrong guidelines, older guidelines, and gave them 6 months of isoniazid instead of 3 months of HR, combination treatment. You need to think about every little detail. You need to think about, am I going to give them combination tablets or separate? No, combination tablets. Who am I going to refer them to? To a racist doctor, for example, in Paphos that will not see them, or will let them sleep on the grass for 2 days before seeing them? Or will I send them to a neighboring town where there is a friendly doctor that likes to see immigrants with latent TB? You have to think about every little detail, or else it's not possible. You have to download a good translator software to your phone. You have to familiarize with the 3-alpha code. You need to define where these people come from. Because remember, the tuberculin skin test is deemed positive or negative depending on where you come from. It's different if you come from Syria or from high incidence countries like Congo. There are 2 Congos actually. So you have to learn a lot of things. But in order to learn, you have to be humble and willing to learn. So I think we did a good job. The clinic is now empty. So active TB cases have dropped from 80 to 100 per year. I get the information every year from the Ministry of Health to like 30 have dropped. So it has an effect. It's effective. The second message, my colleagues up there that did not cooperate with me back then now are continuing this program. The doctors in the major cities, the pulmonary doctors, are continuing to accepting patients which are not sick yet. So, and I think it's a plus. Actually, sometimes I want to go back to the mountain and continue it and leave the university. But my students are also a big intrigue. Can I tell you something? This was the first time in my life that I did this. The first time. Because I was seeking for a baby. I was seeking for a new thing, to do a new thing. I didn't want to just continue what the others were doing. This is not interesting to me.
You set this up, and how you say people continue. How do you make for the future it viable? How do you make sure it's going to continue in the future, even when you decide to go somewhere in unity? How do you make sure it's going to stay?
The authorities are making sure, because I proved to them that it's good for the patients, it's good for Cyprus, it's good for the Ministry of Health because they're making money, and it's good for our hospital up there because they are making money and they have a giro, So when I left, my director, Dr. Marinos Lemesios, he forced the other doctors to continue the program. Okay? And now they're happy with it. It's just, that people don't see it from the start. You have to be a visionary to see it from the start. I'm not saying that I'm a visionary. I'm just saying you in your careers, it's always good for you if you do something new and you're intrigued and you go to work every day and you are excited, not to, I have to see the outpatients, the inpatients, I have to follow the goddamn guidelines. No, I'm going to do my thing. Yeah.
I got I think a final question from me, but for the medical students and young doctors who are listening, do you have a piece of advice you'd like to give them that you've learned from your career?
I have 100 pieces of advice, but we have no time.
Okay.
Chase your dream.
Yeah.
I worked in America, in Germany, in Greece, now in Cyprus, and never say, I'm gonna go into pension here. When you say this, the next year you are gone. So dream, use your profession, because your profession is a passport for the whole world. No other profession is like medicine. law, architecture, everything is country specific and restricted. Most of the professions. Dream on, like the Aerosmith says, dream on, work hard, but according to your beliefs. And when you are in the wrong environment, with the wrong colleagues, just change environment. Yeah, just change environment. Because you have a passport to the whole world, science passport to the whole world. Okay? Yeah, and never be a racist. If you're a racist doctor, who cares? Who cares about you? You are doomed. Yeah, I mean, for me, it's a drive. And never settle. Because then you are dead. You're brain dead, you know? You're not positioned to make any meaningful impact into people's lives or into medicine.
Yeah, thank you enormously for your time. Yeah.
How do we say thank you in Dutch?
Thank you, Val.
Huh?
Thank you, Val.
Thank you, Val. It was a great honor for me to be here. And, you know, these are not my ideas that we discussed. These are transmitted through generations. I was lucky to be a friend and cooperator of Rich Light. You know, Rich Light died last year. He was such a person. He was such a doctor, compassionate and scientist. You know, the better scientist you are, the more compassionate you can be because you have knowledge to give away, right? Okay, it was an honor. Thank you so much for spending your time with me. And I'm at your disposal.
No, thank you. I mean, we're at your disposal more like. Thank you.